Hello, everyone, and welcome to today's webinar, PCOS and Fertility, the latest on nutrition, insulin, and Ozempic, featuring Dr. Sara Arian from Boston IVF. Before we get started, I would like to go over a few quick items about today's event. First, all physicians in attendance today will receive an AMA PRA Category 1 credit, and all other providers will receive a certificate of completion for 1 contact hour credit. Their certificate will be emailed to you by Harvard around mid-summer. Now, without further ado, I would like to introduce today's speaker. Dr. Sara Arian is double board certified in reproductive endocrinology and obstetrics and gynecology. Dr. Arian earned her bachelor's degree at the University of Toronto in Canada, received her medical school degree from Iran University of Medical Sciences, completed her obstetrics, gynecology, and reproductive sciences residency at the University of Texas Health Science Center in Houston, completed her fellowship in reproductive endocrinology and infertility at the Cleveland Clinic and Baylor College of Medicine. She received her master's in clinical research at Baylor College of Medicine. She is an expert in all facets of reproductive health and fertility care, including robotic and laparoscopic surgeries. She has a particular interest in fertility preservation for cancer patients and reproductive and fertility sparing surgeries. All right, we're going to get started. I'm going to pass it over to Dr. Arian. You're ready to get started.
Okay, great. Well, thank you so much for this kind introduction. Hi, everyone. It's a pleasure to be here today to talk about this very common reproductive hormonal condition, polycystic ovarian syndrome, and how it impacts fertility, as well as talk about the latest on nutrition and some of the weight loss options for these patients with PCOS. So with that, I am going to get started. I do not have any financial disclosures. Some of the objectives of my talk today include defining polycystic ovarian syndrome, also known as PCOS. I will be going over the prevalence, risk factors, and underlying etiologies of PCOS, as well as reviewing some of the recommended evidence-based evaluation for PCOS and role of lifestyle factors. My hope is that we can become familiar with different PCOS treatment options and preventive interventions, as well as going over some of the slides and reviewing some points on the latest on nutrition for PCOS patients who are trying to conceive. I'm also hoping to review some of the potential nutrition and health implications of some of the newer weight loss medications, including the GLP-1 receptor agonist medications for women with PCOS who are considering weight loss, and to be able to develop strategies to support PCOS patients who are on these medications and how to transition off when they are ready to try to conceive. And it is always very important to emphasize and focus on how it's important to individualize and personalize care of patients with PCOS. So why is it important to talk about PCOS? It is because polycystic ovarian syndrome is the most common female endocrinopathy in reproductive aged women or individuals with ovaries, impacting up to 5 to 10% of females and women in their reproductive years. Why is it so important to diagnose PCOS? PCOS not only is an important reproductive and hormonal disorder that can have reproductive and fertility implications, it also does have important long-term health implications, as you all know. PCOS is shown to increase their risk and likelihood for developing complications, including type 2 diabetes and insulin resistance, metabolic abnormalities, including metabolic syndrome, dyslipidemia, and chronic hypertension, as well as long-term cardiovascular impacts, increasing the risk for cardiovascular disease. non-alcoholic fatty liver disease, as well as endometrial hyperplasia and increased risk for developing endometrial cancer, and other complications such as obstructive sleep apnea have been reported in patients with PCOS. More importantly, PCOS can have long-term psychological impacts on the individuals, including increased risk for developing depression and anxiety, eating disorders, and body image issues, in addition to some other long-term psychological and emotional impacts. When we talk about pathogenesis or pathophysiology of PCOS, this is a very complex and incompletely understood disorder. There are multiple factors that can be involved in the pathophysiology of PCOS, most importantly, inappropriate gonadotropin secretion from the pituitary gland, as well as insulin resistance that can result in hyperinsulinemia in patients with PCOS. Hyperinsulinemia can then result in decreased sex hormone binding globulin secretion from the liver, which then leads to increased levels of free androgens, including free testosterone and DHEAS, which is secreted by the adrenal gland. And insulin resistance is commonly seen in about 50 to up to 80% of patients with the diagnosis of PCOS, resulting in hyperandrogenemia in about 60 to 80% of patients with PCOS. PCOS is a hypothalamic pituitary ovarian dysfunction. PCOS is a hormonal disorder in which the pituitary gland is unable to communicate appropriately with the ovaries to send the appropriate hormonal signals, including FSH or follicle stimulating hormone and LH, to stimulate growth and release of an ovarian follicle and trigger ovulation every month. And this will therefore result in complete lack of ovulation and absence of ovulation and ovulation, which is commonly seen in many individuals with PCOS, or oligoovulation and irregular, unpredictable ovulation. When we talk about the pathophysiology of PCOS, just like I said, it's a hypothalamic pituitary ovarian dysfunction. And compared to normally cycling and regularly menstruating individuals and women, most individuals with PCOS are found to have higher levels of serum LH, as well as a low to normal FSH level and a higher LH to FSH ratios. There's increased LH pulse frequency and pulse amplitude in patients with PCOS. And because of the oversecretion of androgens and because of increased aromatization of androgens, including testosterone to estrogen, there is a chronically elevated state of elevated estrone and other estrogen hormones that can then result in a negative feedback effect on the brain, resulting in lower concentration of FSH. It is important, though, to note that gonadotropin levels, so FSH or LH levels or ratios, are not reliable diagnostic criteria for diagnosing PCOS. PCOS is an ovarian abnormality disorder. It's an ovarian dysfunction disorder in which the ovarian cortex become thickened and sclerotic, and there's increased ovarian size and stromal volume. On the ultrasound, in most patients with PCOS, there's evidence of multiple small follicles located in the periphery of the ovary and the ovarian cortex, which will give the ovaries the appearance of chain of pearls. And 80% of patients with PCOS have this classic polycystic ovarian morphology that is observed on the ultrasound. When we talk about pathophysiology of PCOS, just like I said, insulin response is exaggerated or prolonged in patients with PCOS, in contrast to regularly menstruating individuals, which can result in insulin resistance, which is seen in many patients with PCOS, regardless of their weight and their BMI. Insulin, through different mechanisms, will then result in stimulation of secretion of androgens. So insulin can stimulate ovarian and adrenal androgen production directly. It can inhibit hepatic sex hormone binding globulin, and 25 to 50% of women with PCOS, interestingly, do not have any evidence of insulin resistance, while insulin resistance is commonly seen in many patients with PCOS. Insulin can also stimulate adrenal steroidogenesis directly by enhancing the sensitivity to ACTH and increasing pituitary LH release. And there have been defects in insulin receptors that have been found in up to half of patients with PCOS, which is another mechanism for elevated levels of insulin in patients with PCOS. So when we talk about insulin resistance, just like I said, it's a common feature in both obese and lean PCOS individuals, and has an overall prevalence of about 50 to 75%. In patients with a higher BMI and obese patients with PCOS, this can impact up to 70 to 80% of the individuals, while it is less commonly seen in people with lean PCOS in up to 20 to 25% of those patients. Interestingly, up to 35% of individuals with PCOS can have impaired glucose tolerance, and 7 to 10% of these individuals meet the diagnostic criteria for type 2 diabetes. And even more interesting is that patients with type 2 diabetes have been found to be 6 times more likely to have PCOS compared to similar non-diabetic patients of the same age and weight. There are some genetic influences as part of the pathophysiology of PCOS. And there's a clear familial pattern of PCOS that has been seen in affected moms and daughters. And this indicates a role for genetics and genetic factors. In patients with PCOS, up to 35% of their moms and 40% of their sisters are also found to have PCOS. Now, identifying causative genes for PCOS continues to remain a challenge in our field, and this is mainly due to phenotypic heterogeneity as well as lack of a male phenotype that makes the linkage studies more difficult to be performed. Current evidence implies that PCOS is a multifactorial polygenic disorder with heterogeneity within both the phenotype and genotype. And we think that familial as well as genetic predisposition, in addition to environmental risk factors and exposures, can contribute to development of PCOS over time. Really, in summary, it's a polygenic disorder involving the interaction of numerous genomic variants and influence of environmental factors and exposures. So most of you are familiar with the clinical manifestations of PCOS, including oligo or amenorrhea and menstrual cycle irregularities that typically begin in early puberty. And this can over time result in lack of ovulation or reduction in ovulation that then leads to deficient progesterone secretion. As a result of being exposed to chronic estrogen without progesterone, there's intermittent breakthrough bleeding or dysfunctional overflow uterine bleeding, which is also known as the anovulatory bleeding that is commonly seen in these individuals. And because of being exposed to unopposed estrogen, this can be associated with increased risk for developing endometrial hyperplasia and abnormal endometrial cells, resulting in endometrial and uterine cancer over time. There's the feature of hyperandrogenism, including signs and symptoms of virilization, hirsutism and hair growth, acne and skin breaking out, as well as hair thinning and androgenic hair loss, resulting in male pattern baldness. These individuals oftentimes complain of abdominal or central weight gain, difficulty losing weight, as well as visceral adiposity. And 50 to up to 90% of individuals with PCOS have been found to have increased serum androgen levels, including elevated free and total testosterone and elevated adrenal DHEAS. Diagnosis for PCOS is a clinical diagnosis, and we commonly use the Rotterdam criteria. So based on the Rotterdam criteria, an individual needs to have at least 2 out of the 3 criteria, not necessarily all 3 criteria, to be PCOS. Number 1 criteria, which is the hallmark of this condition, includes menstrual irregularities due to anovulation or oligoovulation. The second criteria, just like I mentioned, would be any evidence, any clinical or biochemical evidence of elevated androgens, as well as enlarged polycystic ovaries or ovarian morphology on the ultrasound. And this is defined as 12 or greater than 12 small follicles in each ovary, even in one ovary, measuring 2 to 9 millimeters, and or increased ovarian volume of greater than 10. And these are some of the ultrasound images that I showed earlier of polycystic looking ovaries, giving the ovary the appearance of chain of pearls. So as you all know, PCOS is a leading cause of infertility and subfertility, mainly as a result of infrequent irregular ovulation or complete lack of ovulation. Some of the other hormonal causes of anovulation include pregnancy, obviously, thyroid hormone abnormalities and thyroid dysfunction, hyperprolactinemia, late onset or adult onset congenital adrenal hyperplasia, obesity and insulin resistance, as well as ovarian failure, Cushing syndrome, and androgen secreting ovarian and adrenal tumors. It is important as part of the evaluation for PCOS to exclude all other causes of chronic anovulation. So ruling out pregnancy, as well as screening for thyroid dysfunction, checking a serum prolactin in all individuals suspected to have PCOS would be important. It is also recommended to perform a 2-hour glucose tolerance test or hemoglobin A1C, which is more commonly performed in our clinical setting, as well as a fasting lipid profile and checking serum androgens, including total and free testosterone and adrenal DHEAS. Checking a 17-hydroxyprogesterone and screening for late onset or adult onset congenital adrenal hyperplasia is also important in individuals who are suspected to have PCOS. And we like to check a early morning follicular phase 17-hydroxyprogesterone. And if the levels are persistently elevated and abnormal, we oftentimes refer these patients to our endocrine colleagues to have an ACTH stimulation test, also known as a cosentropin stimulation test, performed. As far as treatment options for PCOS, lifestyle modifications would be the first line in management of these patients. So weight loss is clearly important and key for individuals who are at a higher BMI. Counseling to incorporate and maintain a healthy diet, regular exercise and being active, and maintaining a healthy BMI would obviously be very important in these individuals. We oftentimes encourage them to consider having a Mediterranean diet and incorporating a Mediterranean diet into their daily diet and as part of their lifestyle. And even with small reduction in the weight of about 2 to 5%, this has been shown to result in significant improvements in metabolic and reproductive functions in these individuals. When we talk about medications and supplements that can be used for people and individuals with PCOS, Metformin is an important medication that is used as an insulin sensitizing agent in some patients with PCOS. So Metformin is an insulin sensitizing agent which acts by inhibition and suppression of hepatic gluconeogenesis and opposing the action of glucagon. Metformin has some other mechanisms of action, including increased glucose uptake by the muscle and the muscle cells, as well as decreasing the intestinal absorption of glucose and overall improving insulin sensitivity. Some of the other additional impacts of metformin include alterations in the gut microbiome, as well as increased GLP-1 or glucagon-like peptide 1 levels, as well as enhancement of autophagy and normalizing mitochondrial function, resulting in reduction in the chronic inflammation and the inflammatory state that most individuals with PCOS have. So metformin is used to improve overall metabolic parameters. It can help with decreasing weight and some weight loss and improving BMI in patients who are at a higher BMI. It can have some other metabolic advantages and benefits, including reducing blood pressure and LDL cholesterol, and it overall reduces chronic inflammation and improves the chronic inflammatory state in most patients with PCOS. When we talk about some other supplements, including over-the-counter supplements for patients with PCOS, one commonly used supplement is inositol, which is a natural isomer of glucose that can help with supporting and structuring the cells, and it can help with cellular growth and development. Inositol has been shown to help with glucose metabolism and glucose tolerance, and it is also involved in the transport of glucose and its conversion to glycogen. As a supplement, inositol is commonly used and known as myo-inositol, and it's a supplement that can help with lowering the risk for metabolic syndrome and some of the metabolic abnormalities, including minimizing the risk for developing insulin resistance, glucose intolerance, prediabetes, and diabetes in patients with PCOS. It can also help improve ovarian function, as well as help regulate ovulation and menstrual cycles in some patients with PCOS. And so it's a very commonly used supplement that we encourage patients to consider taking. Typically 2,000 milligrams BID would be the recommended dose for inositol, which can be purchased over the counter. Now, when pregnancy is desired for patients with PCOS, something that we commonly take care of and we commonly see in our routine REI practice, some of the options include ovulation induction medications, including the oral ovulation induction agents, including clomiphene citrate or Clomid, which is a selective estrogen receptor modulator, as well as letrozole or Femara, which is known to be an aromatase inhibitor. I'm not going to get into the mechanism of action and all the details of these drugs, medications, but just know that we rarely offer or use injectable gonadotropins and FSH in clinical practice because of the very high risk for twins and triplets and higher order multiples in patients with PCOS. And in most patients who have already failed the oral agents, our preference is to have these patients proceed with IVF or in vitro fertilization. There was a landmark study that was performed evaluating the effects of letrozole versus Clomid for patients for treatment of infertility in individuals with PCOS that was published in the New England Journal of Medicine. And based on this randomized controlled trial, letrozole was shown to be associated with higher ovulation rate as well as a higher live birth rate in patients with PCOS, and therefore letrozole should be considered as the first-line agent or medication in improving fertility and ovulation in patients with PCOS. When pregnancy is not desired, as you all know, hormonal protection of the endometrium and help with regulation of menstrual cycles would be key. And for this purpose, the oral combination pills or contraceptive pills are the most commonly used approach, including different forms of hormone, including transdermal estrogen, cyclic or continuous progestin-only regimens, as well as a hormonal IUD. For treatment of hyperandrogenism symptoms, the combination oral contraceptives are used to suppress LH-dependent ovarian androgen production, and they can also stimulate hepatic HSBG or sex hormone binding globulin production, helping with some of the excess androgen signs and symptoms. And then there are anti-androgen drugs and medications, including spironolactone, which can be used up to 100 milligrams BID, as well as finasteride that can be used for treatment of elevated androgen symptoms. These medications are contraindicated in pregnancy and must be used with a reliable form of contraception, as they can adversely affect sexual development in the male fetus in the setting of pregnancy. And then it's always important to consider routine health maintenance in patients with PCOS and regular screening for insulin resistance as well as diabetes by performing either a baseline 2-hour oral glucose tolerance test or a baseline hemoglobin A1C. And just like I mentioned previously, screening for dyslipidemia as well as routine monitoring for blood pressure and cardiovascular function, as well as routine screening for metabolic of their metabolic profile, and screening for metabolic syndrome would be important in all individuals with PCOS, regardless of their fertility and their age. We also talk about screening for endometrial cancer and using an endometrial biopsy to screen for any endometrial abnormalities. And the decision to perform an endometrial biopsy in individuals with PCOS should be based on age as well as some of the other underlying risk factors, including duration of potential exposure to unopposed estrogen. So severity of other risk factors, including chronic anovulation, obesity, and insulin resistance, should be taken into consideration when we are screening for endometrial cancer. Based on the ultrasound finding, grossly increased endometrial thickness of 12 or greater than 12 millimeters can be suggestive of the possibility of endometrial hyperplasia, and an endometrial biopsy is going to be indicated in these cases. But it's important to note that having a normal endometrial thickness on the ultrasound by itself does not exclude this diagnosis. In the next few slides, I would like to go over some important points about PCOS and obesity. A lot of studies indicate that the prevalence of having a higher BMI and being overweight and obese in those with PCOS can be as high as 80%. Obesity by itself is an individual risk factor for having issues with fertility, resulting in subfertility and infertility by causing impairments of the HPO axis, but also directly impacting the quality of the oocytes and causing poor oocyte quality, as well as alterations in the endometrial receptivity and the endometrial environment, making the endometrium a suboptimal environment for embryo implantation and embryo development. So incretins, including GLP-1 and GIP, are two primary hormones that are secreted from the intestine that stimulate insulin secretion from pancreatic beta cells. GLP-1 is the glucagon-like peptide 1, and GIP, which is the gastric inhibitory polypeptide. These hormones exert their impacts and effects by binding to their specific receptors. So there's the GIP receptor and the GLP-1 receptor, which belong to the G protein coupled receptor family. And after binding to their receptors, this will then activate and increase the level of intracellular cyclic adenosine monophosphate in the pancreatic beta cells, which can then result in stimulation of insulin secretion. So based on this, the GLP-1 receptor agonists were designed. So these are glucagon-like peptide 1 receptor agonist medications, and a class of drugs or medications that are used to treat type 2 diabetes and obesity by mimicking the actions of the hormone GLP-1. And how they work is that the GLP-1 receptor agonist activates the GLP-1 receptor, which then helps control the blood sugar and insulin levels and helps with promoting feelings of fullness and satiety. They are typically used as injectable medications, so they're injected sub-Q into the adipose tissue. So some of the GLP-1 receptor agonist medications include the older first generation drugs, including exenatide, and some of the newer medications, including semaglutide, also known as Wegovy or Ozempic, liraglutide, also known as Saxenda, and some of the newer medications, including Trulicity and tirzepatide, also known as Mounjaro. So what are some of the roles of these GLP-1 receptor agonists in patients with PCOS? GLP-1 receptor agonists are increasingly recognized as a potential treatment option for many individuals with PCOS, primarily due to their ability to promote weight loss and improve insulin parameters and insulin sensitivity, and to potentially regulate menstrual cycles by addressing some of these underlying metabolic issues in patients with PCOS. In PCOS patients, GLP-1 receptor agonists impacts multiple organs, as you can see on this slide, including the brain, the liver, stomach, muscle cells, and pancreatic beta cells to help promote weight management by reducing the appetite, causing delayed gastric emptying, and promoting early satiety. And these can all help improve insulin sensitivity by stimulating insulin secretion in a glucose-dependent manner. Furthermore, these GLP-1 receptor agonists can also have cardiovascular benefits in addition to some of the reproductive health benefits in these patients. These medications can offer cardiovascular benefits by improving lipid profiles and reducing chronic inflammation, which are important considerations for patients with PCOS with increased cardiovascular risk factors. The indications for using these medications and drugs, as you all know, include obesity with BMI levels greater than 30. Also for individuals who have BMI level greater than 27 and risk factors, including risk factors for metabolic dysfunction and metabolic impairment, including underlying medical conditions such as hypertension, dyslipidemia, obstructive sleep apnea, impaired fasting glucose and glucose tolerance, type 2 diabetes, as well as cardiovascular disease. The expected weight loss has been reported to be up to 10 to 15% of body weight for semaglutide over time, as well as up to 30% of total body weight for some of the newer agents, including tirzepatide. It's important to note that these medications are intended to be used for a long term. And some of the common side effects for these medications that are generally tolerable include GI side effects such as nausea and diarrhea, hypersensitivity reactions, including injection site reactions, and some of the other common side effects, including headaches. It is also very important to discuss with patients about their rebound weight gain after discontinuation of these drugs and medications. Most patients regain about 2/3 of their weight or their lost weight after 1 year of discontinuation of these medications. So when prescribing GLP-1 receptor agonists, these medications are prescribed and administered on a weekly basis, starting at the lowest dose and gradually increasing based on the response and side effects profile. It's important to have the patients check in every few weeks to check on their nutritional status, as well as the rate of their weight loss, activity levels, as well as their overall mental and emotional health. No lab monitoring is required or needed when taking these medications. Some of the important contraindications for taking these medications include any personal or family history of multiple endocrine neoplasia or MEN type 2, as well as history of pancreatitis, pregnancy or lactation, and these medications should not be used within 7 days of receiving anesthesia. So, as per the guidelines by the American Society of Anesthesiology, these medications should be stopped within 7 days of a scheduled procedure where anesthesia is going to be required due to delayed gastric emptying, potentially causing respiratory complications at the time of anesthesia. What about pregnancy, and what are the recommendations during pregnancy? Most recommendations come from some of the limited studies that have been done on animal models, and that these pregnant animal models were given these drugs, medications during early pregnancy and early organogenesis. Most of these studies did report decreased fetal weight and increased incidence of external, visceral, as well as other skeletal abnormalities in the animals that were given these medications during early pregnancy. There was an interesting study that was published in JAMA in 2023 looking at the safety of GLP-1 receptor agonists and other second-line anti-diabetic agents in early pregnancy. And in this study, they evaluated 50,000 patients with diabetes, with the diagnosis of diabetes across 6 countries. And a subset of 15,000 patients that were that had a prescription for a second-line diabetic medication from 90 days prior to pregnancy until the end of the first trimester of pregnancy. And they did look at some of the major congenital malformations up to 1 year after birth compared to insulin, which is commonly used for these patients. So this study was interesting. In this study, the infants that were born to women with pre-gestational type 2 diabetes were found to have a higher prevalence of major congenital malformations, including cardiac malformations, compared to infants of the general population. In infants that were born to women with type 2 diabetes that were treated with some of the second-line drugs and agents, they did not observe a greater risk for having major congenital malformations after preconceptional exposure to some of these medications, including GLP-1 receptor agonists, compared with insulin, which was interesting. And although this data can be a little reassuring, we still obviously need more confirmation from other studies and larger studies that are needed, and continuous monitoring, which can hopefully help provide us with more precise risk estimates in the future as we continue to collect data for use of these medications in pregnancy. Based on the current recommendations, we know that there is not enough information to say that GLP-1 receptor agonists are completely and perfectly safe to use during pregnancy, and it is therefore recommended to avoid taking these medications during pregnancy and lactation because of the potential risk to the fetus, including the reduced fetal weight, growth, and survival, as well as increased risk for congenital anomalies, even if it's theoretic, as well as reduced placental development. If an individual does become pregnant while taking a GLP-1 receptor agonist, obviously the recommendation would be that they should stop immediately. And if planning to become pregnant, we recommend to stop GLP-1 receptor agonists at least 2 months prior to trying to conceive. So what are some of the applications of these drugs and medications to REI, specifically for patients with PCOS, which is the topic of today's talk? So I will be reviewing some of the studies that have been published looking specifically at PCOS patient population and the use of GLP-1 receptor agonist medications. There was a study that was published in Fertility and Sterility. This study looked at the use of Saxenda or liraglutide, 3 milligrams on weight, body composition, and hormonal and metabolic parameters in women with obesity and PCOS. And this was a randomized placebo-controlled study. So this medication, Saxenda versus placebo, was administered in 82 PCOS patients with obesity. And the results of the study show that in patients who were who used Saxenda or administered Saxenda for 32 weeks, they were reported to have a lower body weight, as well as improvements in androgenic profile and glucose metabolism, and some of the cardiometabolic markers were reported in these patients. There was another study, anti-obesity pharmacological agents for PCOS, and this was a systematic review and meta-analysis. And this study included 11 trials with a pretty high patient population, 996 participants. 4 of the included studies were the meta-analysis. And they looked at individuals with PCOS with BMI greater than 30 and use of some of the GLP-1 medications, as well as metformin and phentermine, orlistat, and some of the other weight loss medications. The results of this study showed that use of semaglutide and other GLP-1 receptor agonist medications for these individuals with PCOS and obesity was found to be beneficial for improving their metabolic parameters. And among these medications, again, Saxenda was found to be associated with a reduction in free testosterone and increased sex hormone binding globulin, and improvements in menstrual frequency and cycle regularity in patients with PCOS. There was another study specifically looking at semaglutide treatment for excessive body weight in patients with PCOS and obesity. And this study evaluated the impacts and effects of low-dose semaglutide in 27 patients with obesity and PCOS, kind of a smaller study. The results of this study showed a mean decrease of about 7.6 kilograms in body weight and a mean BMI loss of 3.1 in patients with PCOS and obesity, with improvements in their fasting glucose and insulin parameters. And they found that those who responded with weight loss had also improvements, not surprisingly, in their cycle regularity. And then finally, there was another study, interesting study, looking at the impacts and effects of, again, Saxenda in patients who achieved a pregnancy with IVF. This was mainly done to treat or to have women with PCOS and poor response to first-line reproductive treatments undergo treatment with liraglutide, and later on they investigated some of the IVF outcomes. So in this study, metformin alone versus metformin plus Saxenda were used in 28 obese PCOS patients with infertility. And after using these medications for 12 weeks, followed by 4 weeks of a washout period, they had patients undergo ovarian stimulation for IVF. The results of this study showed that there was a higher clinical pregnancy rate per embryo transfer. It was actually significantly higher in the combined group, GLP-1 plus metformin, compared with the metformin only group. And they also found that the cumulative pregnancy rate in the time frame of 12 months was noted to be significantly higher in the combined treatment group compared to the metformin only group. What are the guidelines from our national society, the American Society of Reproductive Medicine? So recommendations from the 2023 International Evidence-Based Guidelines for the assessment and management and treatment of PCOS state that anti-obesity medications, including GLP-1 receptor agonists, could be considered in addition to active lifestyle interventions for the management of higher weight in adults with PCOS. It is also important that healthcare professionals should ensure effective contraception when pregnancy is possible for women who are taking GLP-1 receptor agonists, as pregnancy safety data are lacking. So really, to summarize the studies as well as the recommendations by the ASRM, GLP-1 receptor agonists can be considered for weight management in patients with PCOS, and the indications are for patients with PCOS with BMI levels greater than 30, and or insulin resistance and other underlying risk factors, but not PCOS alone. It's important to counsel these individuals about having a reliable form of contraception, as well as consideration of side effects, including potential need for long-term use, as well as high risk for weight regain after discontinuation of these medications, and lack of long-term safety data. These are important things that should be discussed with patients when trying to make an individualized treatment plan. So this is obviously a shared decision-making process between the physicians and the patients after discussing all the risks versus the benefits. It's important to screen these individuals with PCOS for any eating disorders prior to prescribing these weight loss drugs and medications. It's obviously important to encourage health-promoting behaviors rather than just focusing on the weight loss piece. And it is important to remind these patients that there are many benefits to having a healthy lifestyle, even in the absence of true weight loss. And one thing that is oftentimes very helpful in managing these patients long term is referral to a registered dietitian who is knowledgeable in PCOS and reproductive health for nutrition, for additional nutritional counseling. So some of the conclusions of this talk are that PCOS is a very common endocrinopathy in people with ovaries. This is not a specific disease or syndrome, but rather a syndrome that is represented by a collection or spectrum of signs and symptoms that can change and sometimes vary and fluctuate over time. Manifestations of PCOS vary in different age groups, and just like I said, can oftentimes transition over time. We talked about the menstrual cycle irregularity, as well as some of the hyperandrogenism signs and symptoms, subfertility, infertility, as well as metabolic complications such as type 2 diabetes and metabolic syndrome. Diagnosis of PCOS is primarily a clinical diagnosis based on the Rotterdam criteria, as well as physical examination using ideally a transvaginal ultrasound, and that having all three criteria is not a requirement for diagnosis of PCOS. Knowing and understanding health implications of chronic and ovulation and their effective management is oftentimes more important than the actual PCOS diagnosis itself. GLP-1 receptor agonist is a valid approach for weight management in patients with PCOS and obesity. We don't have any long-term human data, especially in pregnancy. It is important to individualize and personalize care of these patients based on their age, BMI, ovarian reserve testing, and the rest of the fertility test results, family planning goals, and their other underlying comorbidities. It's important to have these individuals in their reproductive years on an effective and reliable contraception while having them on GLP-1 receptor agonist therapy, and also have a washout period prior to trying to conceive of about at least 2 months. It's also important to discuss rebound weight and weight gain. And this can be a concern while being off of these medications for many individuals, but it's important to encourage continuation of lifestyle changes and modification until medication can be restarted, as these are long-term medications and drugs that these patients need to stay on. So with that, I am going to stop sharing my slides and happy to take any questions that you may have.
Thank you, Dr. Arian. We're now going to begin answering questions submitted during today's presentation. As a reminder, you can still submit questions to the questions panel in your attendee control panel. Dr. Arian, our first question is, how long should I manage my PCOS patient with letrozole or Clomid before referring to an RE with age consideration as well?
Yes, that's a great question. So we always appreciate our general OBGYN colleagues referring these patients to us, especially after having tried a few rounds of the oral fertility agents. So letrozole, just like I said, would be the first line. And we typically like for you to limit these letrozole cycles to about 3 rounds, 3 cycles of letrozole before making your referral. After that, we would be doing and starting a comprehensive investigation evaluation, checking the status of the fallopian tubes and HSG testing, if this is something that has not been done, as well as testing for any male factors, including obtaining a sperm analysis just to make sure that we're not missing a male factor. And then at that point, we would be discussing some of the other treatment options, including an intrauterine insemination, depending on the sperm parameters, as well as IVF or in vitro fertilization with these patients.
Thank you. The next question is, can metformin be used in conjunction with GLP-1 RA to help our resistant obese patients since they seem to have a different mechanism of action?
Typically, and again, the data is lacking, but typically, once the patients are started on GLP-1 receptor agonist medications, most providers end up discontinuing metformin and just having the patients on the GLP-1 in order to minimize the risk for hypoglycemia or any other possible complications or drug interactions. So I have rarely seen them being used both at the same time, and the data is lacking overall.
Thank you. The next question is, it just says help with hair growth. So I don't know if that's in relationship to the GLP-1s or not.
Could be hair loss, could
Yeah.
this question may they may be referring to the male pattern hair loss or the male pattern hair thinning, hair baldness, frontal hair loss, which is a common complaint in many patients, individuals with PCOS. Obviously, after ruling out other hormonal abnormalities, including thyroid dysfunction, we would just consider either anti-androgenic agents, which are oftentimes contraindicated in our patient population, people who are trying to conceive, so won't be able to prescribe spironolactone or some of the other agents, but just the over-the-counter agents, including over-the-counter biotin and some of the other hair supplements over-the-counter could be helpful in these patients.
And then our next question is, what do you recommend for patients who need to lose weight but do not have the time as they are already at advanced maternal age?
So that's a tough conversation. So again, depending on the patient's age. So if we're seeing patients for infertility, for people who are at a more advanced reproductive age, especially considering the impacts of time on their AMH, anti-Müllerian hormone, and egg quantity. Oftentimes, we would just depending on our basically BMI limits and cutoff here at Boston IVF, we would let them proceed with IVF. Or sometimes what I encourage them to do is to start the GLP-1 receptor agonist medication if they can, by making a referral to their primary care physician, to have them get started on these medications for a short period of time while we're waiting for the IVF to be approved through insurance before officially starting the process of IVF. So oftentimes I will let them start even for a short period of time to hopefully be able to achieve a few pounds of weight loss, which is going to hopefully be better than nothing. And then typically we'll have them stop the GLP-1 receptor agonist with the start of the IVF injections because of the lack of data when they're undergoing the IVF stimulation process, the lack of data of these drugs on egg quality, as well as because of the anesthesia requirements prior to egg retrieval, that they need to be off of these medications for at least 1 week prior to undergoing anesthesia. Now, for patients who are undergoing a frozen embryo transfer, let's say they are interested in doing genetic testing or chromosomal testing on their embryos and they're freezing embryos for future use, I would oftentimes have them restart the GLP-1 receptor agonist right after the egg retrieval and kind of stay on these medications until we're ready to proceed with the frozen embryo transfer. Obviously, this is going to be more difficult in patients who are undergoing a fresh transfer right after their egg retrieval, in that we can't prescribe or use these medications.
The next question has to do with Boston IVF, about the BMI limits. So what are the BMI limits at Boston IVF? And I know we have multiple centers, so this might not be the case. What you're going to answer is for Waltham, probably Massachusetts, but some of our different centers have different limitations because we're surgery centers and different rules. So.
Correct. Yes, you're absolutely right. So our procedures for most of our Massachusetts offices and clinical practice, the egg retrieval procedure is going to be performed in our Waltham Outpatient Surgical Center. And the BMI cutoffs would typically be a BMI of 45 and above, typically unable to undergo an egg retrieval in our outpatient Waltham Surgical Center. For patients who are at a BMI between 40 to 45, it's important to have a pre-op anesthesia consultation, or pre-IVF, I should say, anesthesia consultation and clearance from our team of anesthesiologists, who then will clear the patient to proceed with IVF, versus for some of the patients who have some other underlying comorbidities, they may not clear or approve the patient to undergo the process of IVF at our Waltham Outpatient Surgical Center. So in these cases, we refer these patients to like a hospital-based setting, basically, to undergo to start the IVF process and undergo the egg retrieval at those centers.
Great, thank you. And this is our last question. Is there any risk in pregnancy after embryo transfer from having PCOS?
So that's a great question. So PCOS, especially if there is evidence of insulin resistance in an individual with PCOS, insulin resistance by itself has been shown to be a risk factor for increasing the risk for having early pregnancy loss or miscarriages in patients who end up getting pregnant, assisted or unassisted, with PCOS. That's why for patients with PCOS who have elevated hemoglobin A1C levels, and are at increased risk for developing prediabetes or diabetes, we oftentimes start these patients on metformin, and we typically keep them on metformin while preparing for an embryo transfer and early pregnancy until at least the first few weeks or the first 10 weeks of pregnancy, with the thought that metformin can help minimize, and there are actually studies, there have been studies looking at the impacts of metformin in minimizing the risk for having early pregnancy losses or recurrent implantation failure in patients with PCOS. And because of these, we keep these patients on metformin until at least 10 weeks of pregnancy. And then once they start seeing their general OBGYN, we defer to the general OB, and oftentimes they'll have them discontinue the medication in preparation for a screening for gestational diabetes of pregnancy.
That was our last question. So thank you, Dr. Arian, and thank you everyone for attending today's webinar, PCOS Infertility, the latest on nutrition, insulin, and Ozempic. If you have any other questions, please contact myself, Alyssa Cooper, ecooper@bostonivf.com. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate it if you could complete the survey and provide your feedback to help with future educational webinars. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of Boston IVF, Dr. Arian, thank you very much for joining us today, and enjoy the rest of your day. Thank you, Dr. Arian.
Thank you so much for having me. Bye.